This is part 2 of the ASPEN NICU PN Guidelines video series. Today we will discuss intravenous lipid emulsions in the NICU patient and future research directions. Again, I'm Daniel Robinson, chair of these guidelines and a faculty member at the Northwestern University Feinberg School of Medicine. This is the document containing the full recommendations for preterm infants, and you can also see the multidisciplinary panel of workgroup members listed here. Part 1 of this series details the methods used to develop the guidelines, and the one reminder I'll mention is that we only included studies of non-surgical preterm infants. With that, question 4 asks, in preterm infants, compared to lower ILE doses, do higher ILE doses improve growth outcomes? There were 7 studies that could have addressed this question, but 5 included multiple interventions. Therefore, we could not isolate an effect from the lipids in these studies. Studies compared either higher versus lower starting ILE doses with the same maximum dose, an example comparison group with starting doses of 1/2 versus 2 grams per kilo per day, or other studies had the same starting dose and a higher versus lower maximum dose. The highest maximum dose studied was 3.8 grams per kilo per day. With fewer than 3 acceptable studies available to conflate outcomes, we were unable to perform a combined analysis. In a single study, a higher ILE dose did show some benefit in some growth measures during NICU hospitalization. With that limited information, to improve growth, we recommend daily advancement of ILE to a dose of 3 grams per kilo per day if using soy oil ILE or multi-component ILE. We also emphasize need for attention to ILE composition when making decisions on dose for the purposes of preventing an essential fatty acid deficiency. The rationale behind this recommendation included considerations of energy demands during a time of rapid growth in these preterm infants, as well as awareness of the risks of essential fatty acid deficiency. Question 5 addressed the composition of the ILE, considering the vantage point that intervention ILEs were lowering the exposure to 100% soybean oil, and question 5 is, in preterm infants, compared to an ILE containing 100% soybean oil as the sole oil source, does altering the ILE composition by reducing the proportion of soy oil improve growth outcomes? All studies compared a multi-component ILE to 100% soybean oil ILE. Different types of multi-component ILEs were assessed in these studies as detailed here. Different growth measurements could be assessed, such as time to regain birth weight and changes in standard deviation scores in addition to others. All studies advanced the ILE to a maximum dose of 3 grams per kilo per day. Heterogeneity in reporting prevented combined analysis. While most individual studies showed no difference, one study did show, as highlighted in yellow, a more favorable decline in standard deviation score for length and head circumference from birth to 36 weeks postmenstrual age or discharge with a multi-component ILE containing fish oil. Given no overwhelming evidence of benefit from any particular ILE composition, at this time, we do not recommend any specific ILE for growth enhancement. Regarding the rationale behind the recommendation, the method of reducing exposure to soybean oil differed between studies. Some studies compared a multi-component ILE that included fish oil, while others included a multi-component ILE that contained olive oil or MCTs without fish oil. There was heterogeneity in growth measurements and the times that these measurements were assessed. This prohibited combined analysis. To touch on methods a little more, 2 trials had multiple intervention groups. To carve out those groups for comparison, the control group would have been counted twice. To theoretically address this, arbitrarily, one study arm could have been excluded. However, that could not be justified, and even then, this still left an insufficient number of studies for comparison. In short, and to reiterate, we were unable to conflate any data. Question 7a asks, in preterm infants, compared to an ILE containing 100% soy oil as the sole oil source, does reducing soybean oil using any multi-component oil ILE reduce the incidence of PNOLD? This question also took the perspective that soybean oil reduction may prevent PNOLD. All studies compared any multi-component ILE with or without fish oil to 100% soybean oil ILE. PNOLD was defined as direct or conjugated bilirubin either above 2 mg per deciliter or 34 micromoles per liter, or greater than 26 micromoles per liter, or greater than 1.5 milligrams per deciliter for 2 measurements, as stated in each trial. The maximum ILE doses ranged 2.5 to 3.5 grams per kilo per day, and one study also compared different ILE doses, 2.5 and 3.5 grams per kilo per day. In this forest plot, we see that considering multi-component emulsions with or without fish oil, we found no significant risk difference between groups regarding PNOLD. We also asked with question 7b, in preterm infants compared to an ILE containing 100% soybean oil as the sole oil source, does a reduction in soybean oil, this time using a multi-component oil ILE that includes fish oil, reduce the incidence of PNOLD? All studies in this question compared a multi-component ILE with fish oil to 100% soybean oil ILE. While there is overlap with question 7a, this question took the perspective that a reduction of soybean oil and inclusion of fish oil could prevent PNOLD. And in the comparison of multi-component emulsions that all had fish oil compared to 100% soybean oil emulsion, again, we found no significant risk difference between the groups. With that, our recommendations for the purposes of preventing PNOLD in preterm infants, and as a reminder, these are infants without surgical disease, we do not recommend the use of any specific ILE. This table summarizes the secondary outcomes assessed in combined analyses, prematurity-associated morbidities, and key clinical markers, specifying whether intervention was any multi-component emulsion or if the interventions all had fish oil in the emulsion. Most were not significantly different between groups. We did find a significant difference for retinopathy of prematurity in favor of a multi-component emulsion containing fish oil, and we state that this warrants further study. Now, to re-summarize recommendations with all of this in mind, for the purposes of reducing PNOLD in preterm infants without surgical disease, we do not recommend the use of any specific ILE, whether it contains 100% soybean oil as the sole oil source or a multi-component oil ILE with or without fish oil. As identified in supplemental analyses, further study is needed to evaluate the potential of an ILE containing fish oil to reduce ROP severity. In the combined analysis, the risk for PNOLD was similar, whether using 100% soybean oil or multi-component ILE. Therefore, no specific composition can be recommended for the purpose of reducing PNOLD in non-surgical preterm infants. Other than retinopathy of prematurity, no other secondary clinical outcomes were significantly different between the groups, and when assessing the trials individually for ROP, there was no significant difference between groups. This still supports the need for further research to investigate a multi-component ILE with fish oil and ROP risk and underlying mechanisms of action in preterm infants. Regarding limitations and future research directions, We have suggestions of what to keep in mind when looking ahead to future evaluations as occurred in the development of this guideline. To address limitations in combining data, we need consistency in outcomes reporting in the definitions and the measures of central tendency reported. On that note, we need a more unifying definition of essential fatty acid deficiency, or EFAD, and enhanced tests to determine specific doses for specific ILEs associated with EFAD. There should be further attention to ILE composition and retinopathy. We should also account for trajectories of illness and growth established during PN exposures that may then be modified by enteral nutrition. Can we determine if PN or specific parenteral constituents during times of critical illness may be associated with adverse outcomes, specifically in preterm infants? Finally, we need investigation of PN dosing regimens specifically for earlier gestational ages, such as for infants born in the 22nd and 23rd weeks of gestation. Thank you for your attention.